Good afternoon. This is the 2021 protocol update. I know that the State Office of EMS sent out emails saying that they would provide us with a ready classroom presentation, but we have not seen that as of yet, and we've got several people that need to recertify by the end of March. So I wanted to go ahead and get this out there for those that needed it for their research. So without further ado, here we go. All right, so first of all, what's new from the American Heart Association in 2021? Specifically for ALS providers, it involves symptomatic bradycardia. So the old protocol in symptomatic bradycardia, the patients that are alive, is the 0.5 if alive, 1 if done. So unfortunately, this has changed. The new protocol is whether they're alive or dead, you're going to use atropine at 1.0 milligrams IV. This still can be repeated every 3 to 5 minutes up to a maximum dose of 3 milligrams. Now just remember that atropine administration should not delay the implementation of external pacing for these patients if they need it. Now, the American Heart Association has finally concurred with field expertise that SpO2 levels in most people with pre-existing respiratory disease are at a normal baseline of 94%. And now by pushing for 100%, we are actually over-oxygenating our patients. They are now recommending 92 to 98%. So when you have a patient who has a return of spontaneous circulation, the new protocol reads that if ventilatory assistance is required, you're going to ventilate at 10 to 12 breaths per minute. You're not going to hyperventilate. You want to avoid excessive ventilations, start at 10 to 12 breaths per minute. If capnography is available, we want to titrate that to a target of 35 to 40 millimeters of mercury. We're going to titrate oxygen to minimum necessary in order to achieve an SpO2 of 92 to 98%. So start with 100% oxygen during the CPR phase. And then BLS, I'm going to apologize because I see that it is, the picture is over top of the words, but BLS, you are still going to titrate that oxygen to a minimum necessary needed to achieve the SpO2 of a 92 to a 98%. Another change that has occurred to newborn infant care, which is protocol 4410 or 6410, involves suctioning. So during newborn infant care, suctioning of the mouth and nose once the head is delivered has a tendency to induce bradycardia and hypoxia. So suctioning is recommended only if there is believed to be an airway obstruction. So the new protocol reads that you want to position the patient supine with the head in the sniffing position. You're going to suction only if it is believed to be an airway obstruction, and you want to be very aware of bradycardia and hypoxia. If copious secretions are noted, they want you to place the infant on his or her side with the neck slightly extended. Continue intermittent suctioning. Now there are some general education updates that have been put out there, and one of those is that they consider it reasonable to utilize cuffed ET tubes over the uncuffed ET tubes for both infants and children, and the equipment lists by the Office of EMS has been updated to reflect that modification. And just remember that our pediatric patients should be ventilated at 20 to 30 breaths per minute any time that ventilation is required. Now, one thing that has been added is talking about the Jackson-Pratt drain. Now, these are most often used after surgery in order to remove drainage from the surgical site. The Jackson-Pratt drains are often used before surgery to drain any infected areas, and they're round or grenade in shape and made of flexible plastic that's attached to a tube, and that tube actually remains in the patient. So with the Jackson-Pratt drain, We want to perform the initial treatment universal patient care protocol, follow the proper protocol for medical management based on how they are presenting to you, and make sure the patient has been provided discharge information that details how they are to utilize the device once they get home. So we want to make sure they're properly educated before they leave the facility. In terms of the BLS provider that's able to monitor this device now, you want to make sure you note the length of the exposed tubing outside the patient and try not to manipulate the patient in a manner that could pull on the device or cause it to be changed in length or even pulled out altogether. So you want to make sure to note the length, and it should not change during the transport. Monitor the patient for any complaints that are related to this area, and this should not change during the transport. The whole time it should be pretty stable. If any new discomfort occurs or that discomfort increases, then the tube, or if the tube becomes dislodged, you want to contact medical command. Chest tubes vary in diameter and are plastic tubes that have been inserted through the chest wall. Your chest tubes are meant to remove air, fluid, or pus from the intrathoracic space. So for BLS providers, you are able to monitor these devices now. You want to, again, just like we did with the Jackson-Pratt drain, you want to note the length of the exposed chest tube that's coming out of the patient. You want to make sure you don't manipulate the patient in a manner that could pull on the device. The length should never change, and the attached drainage tube should never be placed above the insertion site at any time. You want the contents to drain out of the body, not drain back in. You want to monitor the patient's breathing and note that it remains normal, and if anything changes during the transport, if the patient becomes labored in their breathing or the chest tube becomes dislodged, you need to contact medical command and transport the patient to a local or nearest emergency department. And last but not least, BLS monitoring of IV therapy patients is intended for IVs that have been established and running, but whose medical condition is not dependent on the fluid resuscitation. It is not intended to be an interfacility transport protocol for the patient that needs IV fluids as a medical treatment to prevent deterioration of their condition. So when it comes to BLS monitoring of IV fluids, there must be clear, non-medicated normal saline. However, lactated ringers may be utilized during a shortage of normal saline, but the IV fluids can only be gravity fed. You cannot take, as a BLS provider, any IV fluids that are on a pump. It has to be gravity fed. And the IV must be established by the initiating facility staff, and it's in the venous peripheral only. It's only in the arm.